Good evening, everyone. We welcome you all to OrthoTV original webinar series. This is the longest running webinar series of OrthoTV since the lockdown. And to introduce today's speaker and topic, I hand over to our moderator for the day, Dr. Salim Patel.
Yeah, thanks, Neeraj. Good evening to all our viewers. Welcome to this another trauma series, what we have started again in this year in 2021. Today we have a very interesting topic, but before that, I would like to introduce our speaker for the day. It's none other than Dr. Manoj Pahukar from Nagpur. He's a senior orthopedic surgeon from Wockhardt hospitals in Nagpur, has special interest in complex trauma, joint replacement, and pelvic-acetabular surgeries. He's done his AO fellowship from Hong Kong in 2013, a debut fellowship from Ghent in Belgium in 2005. He's been the secretary of the Vidarbha Orthopedic Society in 2013, an organizing secretary at the MOECon in 2014, and VOSCon in 2016. Sir has been an AO faculty at various AO courses and has also been a national faculty at various national and international conferences as well. So with this, before I hand over the session to Dr. Manoj, he would be talking about a topic which is a very keen interest of today, that is fixation strategies for complex fractures of the shaft humerus, a case-based algorithm. So I would now ask Dr. Manoj to share the screen. Over to you, sir.
So thank you, Dr. Salim. Very good evening to all of you. I welcome you all for this webinar. Greetings from Nagpur, Central India. So first of all, I would like to thank the organizers for conducting such wonderful academic sessions throughout. A special thanks to Dr. Neeraj, Bijlani and Dr. Salim Patel and Zydus Pharmaceuticals. So the topic which I am going to present today is about dilemmas in complex shaft humerus scenarios, the various fixation strategies we use, and I will try to present a case-based algorithm for these injuries. As you are all aware, once a shaft humerus fracture comes to your casualty, I think every orthopedic surgeon have their own protocol, set of surgical skills. So they will either try to plate it, tail it, or do some other kind of fixation modalities for this fracture. There are various fixation modalities which are available. Everything is now getting comparable. So there is always a controversy as to which thing is better for that particular fracture, whether you should go for plate, nail, fixator, or ender nail. I think everything has got its own role. So that controversy as to which is best still remains. But what I will try to deliver in next 30 minutes is about the which fixation method you need to choose based on individual case scenarios. So I will start with these two cases. The first, you can see this is a shaft humerus diaphyseal midshaft fracture in a young male, severe comminution, as you can see at this level. And he underwent with this surgery of an anterolateral plating of this humerus has been done. You can see the length of plate with 3 screws proximally, 3 screws distally, 1 interfragmentary screw through the fracture, the comminuted segment. So is this good enough? Is this a good adequate lead, good distal fixation, good reduction? So will this unite or will this fail? So further ahead down the line, 6 weeks, as correctly pointed out, this doesn't seem to be in a good alignment. The plate length seems less. Even the number of screws which needs to be placed distally away from the fracture site seems to be less. So we're thinking that this will not unite, but luckily for this patient, at the end of around 12 weeks, you can see the amount of callus formation which is happening in this fracture, and at the end of around 5 months, the fracture has completely united. So what has helped in this case particularly? I think it is basically we don't need a good axial stable implants always in cases of shaft humerus. We need a good amount of rotational stability. We need a good amount of cortical purchase. Since he being a young patient, even these 3 screws have given a good amount of stability so that this fracture is united. So you can see there is some amount of varus malunion, but I think this is easily accepted. Even the patient demanded implant removal, which was done later on. Now we'll go ahead with the second case. Now here in this case scenario, as you can see, again, it's an old patient, 67-year-old. He was having this kind of transverse diaphyseal, again, humeral shaft fracture, you can see the amount of osteoporosis, you can see the wide canal, and also if you can see these fracture lines in the proximal segment extending proximally. So here the patient underwent this surgery with the posterior plate fixation, again a good length of plate with a good reduction, 3 screws proximally, 3 screws distally, again locking plate has been used. So again, is this adequate? What will be the chances of healing? Any problems which could occur in this patient? And unfortunately for him, at the down the line around 8 months, this patient presented with atrophic kind of non-linear, where you can see certainly the fracture ends are not united. There is a gap at fracture site. The plate is still there. I think there is an inadequate length of fixation, and maybe sometimes if you feel that intramedullary nailing with a good load sharing devices, especially in this osteoporotic bone, would have been better. So for this patient, for the non-Indian, we went ahead with posterior approach with implant removal. I have put this longer locking compression plate and additional augmentation plate, and graft was done. This was immediate post-op. And as you can see down the line, 3 months, he was completely pain-free. His shoulder and elbow RM was completely good, and down the line over next few months, like at the end of 8 months, he has a complete good union with good functional range of motions. So we had certainly come a long way from simple conservative methods for the shaft humeral fractures to the posterior plate with anatomical reduction, direct approaches, then the intramedullary nails, then enders or the flexible nails, and then nowadays even the anterior bridging MIPO plates. So we think that this is the fractures of this fracture humerus. They are most easy to treat, but I feel they are most difficult to treat as well. You need to understand this humeral anatomy, that the proximal half of the humerus is cylindrical and distal half is triangular, and medullary cavity narrows down from proximal to the distal. So this thing needs to be understood whenever you are trying to fix this kind of fracture. As you can see that middle third fractures are most common amongst them, followed by the proximal third and then the distal thirds. You need to understand the amount of displacement which is going to happen depending on the location of the shaft humerus fracture, near the or above the deltoid tuberosity or below the deltoid tuberosity. You need to understand these forces so as to get a good reduction and fixation strategies so as to oppose these deforming forces. We also know that upper limb humeral fracture, we had a great tolerances of alignment. We need to be more of them of a rotationally and angular stable, and we accept this much of various angulations and varus and shortening in humerus. This is because we had the shoulder and elbow joint, which has a very huge good range of movements which can compensate for humerus. So these are the four basic inventory which we will be having for operative fixation of these fractures, from the plates to the intramedullary nails to the enders nails or external fixation. So $1,000,000 question always remains as to amongst all these for particular fracture, which is the best fixation option in treatment of these fractures. So which implant needs to be used? So I found that it depends on these two important things. Wanted to have some kind of algorithm as to we need to understand the injury or the fracture related factor itself and patient related fracture factors. So these are the individual considerations for that particular fracture which you need to take, whether it's an open fracture associated with any neurovascular injury or not. If there are any associated ipsilateral or sometimes bilateral humeral fracture, whether it's a high or low velocity kind of fracture. A patient is having any polytrauma or associated chest trauma. The patient is obese, having age, osteoporosis. So these considerations in individual case scenarios will lead to you which kind of implant you are going to choose. So this is the most common X-ray, most controversial X-ray. Everybody will have their own opinion as to what kind of fixation they will choose, right from conservative to the plate, to the nail, to the enders nail. All kinds of methods of treatment are there. So certainly this was the gold standard of an posterior plate with direct reduction and anatomical reduction. Both needs to be achieved for such kind of fractures. Then another similar kind of diaphyseal fracture, another fixation option was to get a good intramedullary nailing. Now this is a nail has got advantage being a load sharing device. Again, it is more near the mechanical axis of the humerus. minimal invasive, again could start ambulating them very well. So if you do a technically very good surgery for these fractures without destruction at the fracture site, certainly this is also useful. Then antegrade or retrograde ender snail multiple filling the canal, again could sometimes be used for fixation of these fractures. And nowadays even I find these fractures can be fixed with these MIPO techniques with an anterior bridge kind of plate technique, spanning the fracture with a longer plate with a few 3 screws proximally and distally. Even indirect reduction and a good amount of fracture healing can be seen. So these are the 4 methods individually on individual experience they will try to go for them. So I will try to now find an algorithm as to where you need to use which kind of implant. Like these are the proximal isthmic fractures in this case. So there are huge amount of deforming forces which are happening for these fractures. So I feel that you need to get a good anatomical reduction with a direct technique here. So good plating with a good reduction with support are certainly indicated for such kind of fractures. But also you can certainly go for these fractures with the intramedullary nail as well. If you could get a good close reduction and you can see the amount of callus formation even with nail. Then the second case scenario are the patients who have a failed close treatment either because of loss of reduction and distraction. And in few patients the obese patients or the patients with obvious soft tissue interposition at the fracture site, or the patients who are certainly a few times are not tolerant or compliant, I think nailing would be difficult. And in cases of this failed close reduction treatment of the shaft humerus patient, where overlapping and all these things are there, I think plating would be a preferred method of fixation. Then this is a third case scenario where you can see for the fracture characteristics. So in this mid-shaft humerus fracture, it's a severely displaced and comminuted fracture. It needs to be again either splinted or it needs to be anatomically fixed. So this is the first method where you can certainly go with a posterior approach with a good plate, again interfragmentary cortical screw fixation. And another way to fix such kind of fractures with combination in the mid shaft would be either to bridge it with a nail, or again nowadays this again like a bridging plate anteriorly, again indirect reduction, a good apposition of these fragments, good healing can be seen. This is another option which certainly should be thought of in such kind of case scenarios. So the next case scenario will be to consider in fracture characteristics the distraction at the fracture site. Here you can see that it's a proximal fracture. Again, the bone-to-bone contact is not there. And I feel here the plate fixation with a good reduction of individual fragments and the interfragmentary screws and then plate will certainly suffice for such kind of fractures. Another important characteristic where I feel plates are much superior than nail, like these are the long oblique or spiral fractures. Now here you can see this kind of fracture, and both these long oblique fragments were opposed to each other, and then you can plate it. Another similar kind of fracture in the distal third of the humerus, again plating. Again, here you can see there is a long segment of this oblique overlap with each other. Again, this spanning of all of this segment with a plate fixation will certainly will give you a very good result. So what you need is a precise apposition of these individual proximal and distal fragments, and then fixation will give a very stable rigid fixation. The next case scenario, the highly comminuted fracture, as you can see here, you can understand this will be a very high velocity kind of injury. So again, we don't want to go with a direct approach. I always go for an indirect reduction, avoid the stripping of the soft tissue, and prevent the damage to the soft tissue. And I think the nailing would be the ideal best option for such kind of fixation. And again, this again kind of segmental or severely comminuted mid shaft fracture. Again, the another good method which is now is to go for an MIPO. Again, anterior humeral breech plating spanning this fracture segment with 3 screws on either side can certainly give a good rigid fixation. So the next fracture characteristic would be to like the proximally displaced humerus fracture. Here you can see it needs a buttress from the lateral side. So again, I think plate fixation would be a better option in such kind of fracture case scenarios. The further fracture characteristic on the eighth case, like here you can see either there is an extension of this fracture proximally or intra-articular. Here you can see that fracture line going towards the head. So again, I feel rather than a nail, which will cause a lot of distraction or combination, all these fragments could open up. So better to go ahead with an Philos kind of long plate fixation so as to span this fracture and get a good reduction. So this is another further follow-up X-ray with a good union of this fracture. Another case example, again, proximal humeral fracture basically extending into the shaft. So you need to concentrate more on this articular anatomical reduction prior to your this shaft and meta-diaphyseal fixation later on. So this is the kind of fixation which we can get in such scenario. Another case example, again, mid-shaft fracture of humerus, again that fracture extending quite clearly with CT scan into the metaphyseal and as well as into the humeral head region. So here you need to have some different strategies so as to initially get a good reduction of the head, and you can go for such kind of twisted longer plates so as to span your complete metaphyseal and upper shaft of the region with interfragmentary screws, and this will certainly go for a good union at the end of around 4 months. So you need to go for such kind of plate configurations which would help you in even dealing with such complex case scenarios. So further are the complex distal humeral fractures. Again, in this fracture configuration, you need a good precise reduction so as to get a good elbow functional range of movement. So here we'll gone for this posterior extra-articular, peri-articular kind of plate fixation along with interfragmentary screws to get a good anatomical reduction. Similarly, for these distal fractures, if you have got some canal left distally where you can go for one locking screw at least. So even sometimes this humeral nail will be helpful if there is a lot of diaphyseal mid shaft and lower shaft combination, and you could at least get a good hold purchase at least of one screw with a good medullary fit. Even this would get a good result. So for the 10th example, if the patient is having shaft humerus along with vascular injury, like in this fracture for this patient, he has got brachial arterial as well as radial nerve, brachial arterial injury with radial nerve palsy. So he was explored posteriorly first, fixed this fracture, radial nerve was explored, and then anteriorly brachial artery repair was done. So further ahead now again this case scenario where patient has got proximally shoulder problem, like there is a displaced clavicle fracture associated with brachial plexus and arterial injury with an ipsilateral shaft of humerus fracture. So in this case scenario, certainly the priority goes to your brachial repair along with brachial plexus exploration if needed, clavicle fixation, followed by you need to go for again a plate fixation, because here you should go for a gentle fixation without much of a vigorous manipulations because already you have repaired the brachial artery proximally. So plating with direct reduction is preferred in such kind of case scenarios. So further moving ahead on the 12th scenario is the floating elbow. Again, you can see a very shattered forearm into the segmental radius annuli as well as highly comminuted humerus. So both these simultaneous fixation of fractures needs to take a priority. Again, to have a good elbow range of movement, again a good fixation of both of these fractures with a plate has been done, and you can see certainly a good range of movements can be gained by this patient with these floating elbow injuries. This is another case of a floating elbow injury with humerus and radius fixation. Another case of a floating elbow with you need to have a good anatomical reduction and fixation of both of these fracture. One important thing, like if the patient is having humeral fracture with stiff shoulders or elbow, so again the plating becomes your choice of fixation, because with stiff range of movements, you will not be able to go for a nailing in those kind of patients. So further 13th example, if there is some overlying skin compromise or the open fracture, which limits and to put some implants inside. So again, like external fixation, again for the temporary till the wound heals, again followed by sometimes the ender nails, or in another case scenario where you can see the flexible nails as an option. In such case scenario should always be considered. So minimal implants, avoid plating in cases of open humeral fractures, where especially if a lot of contamination is there. So this is an absolute indication of bilateral fractures of the humerus to go for an intramedullary nailing, because the patient needs to be ambulated very fast, and he needs to start range of activities very early in such case scenarios. Another absolute indication to go for intramedial nailing is the Parkinson's disease. So consider these case examples of a neurological injury. So once you are exploring nerve injury for some problem, so you should always go for fixation simultaneously. So usually plate fixation is preferred, especially you go for these absolute indications for immediate surgery in case of neurological fracture, whenever there is an open fracture or when there are distal third spiral, Houston-Lewis kind of fracture, or patient has developed the radial nerve palsy secondarily after a close reduction or some nailing which has been attempted. So plate fixation takes a priority whenever you are dealing with the neurological injuries. These are the further case example of an associated fracture of the shaft tumor which has been associated with ipsilateral intra-articular fractures either of the elbow or the proximal humerus. So here you can see a supracondylar humeral fracture along with the shaft of the humerus. So again for this posterior approach combining olecranon osteotomy along with the posterior plate fixation of the shaft of humerus along with dual plate fixation for supracondylar humerus was done in this patient. So you need to consider individually for these fractures so as to fix them simultaneously. In compartment syndrome, where chances of infection will be high, you should always try to go for a minimal invasive. Like for this patient, the humeral nail was done, and certainly it has got a good union at the end of 6 months. These are again few particular case scenario examples, 19 scenario, like the peri-implant fracture. Like after plating 10 years back, this lady has got this fracture. And again, the best thing would be to take out the plate if it is possible and go for a replating. Here we will not able to take out few screws. So I put the plate on the other surface which is available for the humerus. Again, a long plate with a good hold of this fragment and a good reduction could certainly solve such complex case scenarios. Another case scenario, the intermedial nail is inevitable to use is like this kind of segmental fracture with considerable soft tissue dissection has occurred. And you also know that again nailing is an important adjuvant whenever the patient is having polytrauma, especially the chest trauma, where our patient is having the lower extremity trauma, where we need to early weight bear through the humerus and ambulate such patients to. Even the Sarmencio has explained that polytrauma surgery patients often require operative management to avoid recumbency, and nailing is a preferred option in cases of such patients. So further ahead, we'll go with the pathological fractures. Again, depending on the pathological fracture location, like here in this case scenario, it's a pathological fracture in the proximal of the humerus. I had gone for this Philos kind of plate fixation with the good screw purchases proximally and distally. And if the location of the pathological fracture is near the diaphyseal, obviously a good intramedullary splinting implant with a nail will be the best choice to tackle such situation. Another, the secondaries in the humerus fracture with a pathological fracture again splinted with a nail again to treat such kind of fractures. Another a complex case scenario of a humeral head with severe loss of bone along with humeral shaft fracture. Again, sometimes you can get lucky with individual case scenario of getting with the nail and good reduction and a good union later on. Another case example which I would like to highlight is such kind of patient demand. Like this patient was been operated with an plate, and he was certainly afraid that this plate has bent. So he didn't want to put plate again. So our choice would be only to take out this plate and go for an intramedullary implant over here. So nailing has been done. This is a good apposition, and certainly the patient demand is also very important factor as to what kind of fixation you are going to plan. Further, the chronic problems like non-union stable internal fixation is the treatment of choice. And usually it is only the compression plate fixation in non-union cases. It has got the best favorable successful results. And intramedullary fixation has been very less successful. And also simultaneously you will get the advantage of drilling, shingling and putting the grafts, opening the fracture site, freshening simultaneously can be done. So this is a complex case scenario of a humeral nail which has failed, which has been taken out, and patient landed up with this kind of non-union. So he underwent the surgery with plate fixation. The bony edges were fashioned, and this plate along with graft was done. And you can see that patient has started getting a good union at the end of 6 months. Another case scenario of a non-union of the proximal of the humerus. Again, a good Philos plate with a good rigid fixation and stable reduction and early mobilization is the key. So as to get a union in such kind of case scenarios. Further case scenario, the failed flexible intramedullary nails. As you can see here, the intramedullary nails which are failed will leading into the non-union. Need to take them out and replace it with the plate and do a bone graft, and you can see ultimately good union. Further down the line, intramedullary nail fail, then you should go for a plating. So this is a classical example of that. Around a 20 years old female had with this nailing. You can see the disadvantage of nailing with shoulder impingement. Even her elbow was stiff, and you can see that patient is still having atrophic non-union. This is because of a severe distraction at the fracture site. So she underwent the surgery with nail removal followed by open reduction of this segment. You can see the atrophic non-union. The fragments were fashioned and shortened. And further, I have put extra-articular, this long plate spanning this fracture. And additionally, I have put the augmentation place medially with usually a very low profile 3.5 mm weekend plate. You can add certainly to achieve an absolute stability followed by iliac crest bone graft. So here you can see postoperatively in this X-ray, we can certainly get a very good rigid fixation. Patient can start early range of movement immediately. Further 3 months follow-up, no painful range of movement. Fracture has started uniting. 6 months, fracture has united completely with a good union and full function. So I must say that this augmentation plate along with an absolute anatomical fixation certainly improves the stability of your construct, and you can start the early range of movements and also help in early fracture healing. So this is another case example of a dual kind of this plate was put, and you can see the kind of callus which you can see immediately at the around 4 to 6 weeks. The early callus phenomena along with augmentation plating has also been seen. Then further down the line that the chronic problems where the patients having non-unions which are associated with significant bone loss or synovial cavities or with failed previous surgeries. So you need to have a more elaborative reconstructive efforts to go for such kind of fractures. Certainly fibula transfer either vascularized or intramedullary grafts along with lot of grafting are certainly applicable. This is the one a case example to demonstrate the kind of lysis which can happen in humeral fractures and the kind of fixation which you need to get to achieve this stability in such kind of complex non-union scenarios. So this is the case which I have done very recently of a old female around 65 years old having failed this flexible nails which has completely bent, and there is a atrophic kind of non-union which has happened at this site. So I opened it through the posterior approach. The nails had to be cut, and then freshening of edges and plate fixation was done. You need to understand, not in this case, but if you have put a intramedullary nail for humerus, the exchange nailing is not a wise option for non-unions of the humerus. So they are more having good success result in the tibia, but it is humerus, they are never advisable. So this is the post-op X-ray of the same patient. Where an intramedullary fibula was also put along with a good cortical graft and posterior plate fixation after taking out the implants. So this is a final good case which I found very interesting of a young male who had this kind of shortened, deformed femur because of some childhood infection in his right humerus. You can see the draining sinuses, lot of infection, and this plate was there in this patient. So in the first stage, I have taken out the plate, debrided the whole wounds, curated the bones, and then put him in an external fixator till a good sound control of the infection has been obtained. And then again for such a deformed humerus, I had to put such kind of plate where again a good stability was achieved. And certainly though we find that this humerus has healed very well even with all these deformities, infection, and problems. So this patient has again having a good functional range of activity. He is not bothered, doesn't want any further functional improvement, so he is doing well. So, in summary, I would certainly like to say that these fractures do have multiple kind of fixation options available to us, but you need to individualize this treatment option for each patient. You need to keep all armamentarium ready. So it's not like I will go for nailing, I will go for plating. Try to have a individualized plan for that particular fracture, other considerations, and try to devise a best strategy for that particular patient. Choose the method which gives excellent and persistent results with your skill. Don't get fancied with many other methods which are available. And radial now, careful documentation is very essential, and most of these will recover spontaneously. So I must say that there is no specific algorithm for deciding, since it is necessary to take into account many factors before reaching a final decision as to which treatment to implement. So you need to have individual specific algorithm for that case. So I hope I am able to make few points clear regarding this complex shaft humeral fractures. So I thank you very much for your kind attention. Thank you.
Thank you, sir. Thank you. An excellent presentation with very good cases shown, especially the one I would like to get your opinion on those failed plates which you had shown, and especially in a non-union fracture. Now, you've done bone grafting in some cases, and you've done a refixation. And in one case, where patient didn't wanted a plate, you had applied a nail in that. So those were really good cases which I had seen. Now, my one of my questions is, sir, like what we have learned in our residency, especially in these non-union cases, maybe 2 or 3 surgeries, still union not possible. We used to do a procedure of rigid fixation in the form of nail and plate together. So that we get a standard anatomical reduction along with the rigid fixation. So your comments on that, have you done any cases like these in which nail and plate both have been applied?
Yeah, absolutely. That's a wonderful point which have come out in cases of complex non-unions where it has failed maybe one time or two times. So what is ultimately needed, you need a good stable rigid fixation in cases of humeral fracture to achieve a union. So whatever method, you can go for an intramedullary fixation and then augment it with a plate also, so as to get a good rotation as well as angular stability. Certainly that construct is again a good enough for such kind of case scenarios and could be certainly useful. I have done 2 cases like that, but maybe because of time may not be able to show the other many
Sure,
cases
sure.
like
No,
that.
excellent, excellent, sir. What is your rehab protocol for such patients, sir, especially in these bad non-unions where you need to protect at times, despite of giving a good fixation?
Fixation.
So what is
Yeah,
your rehab
absolutely.
protocol?
Yeah. I think if I had operated it for the second or third time, so I certainly go for a more of a immobilization for a longer period, at least 4 to 6 weeks, irrespective of whatever fixation I have done, because his shoulder and elbow functions will certainly be compromised even before the surgery. So let the fracture unite completely. Let it settle down. Patient doesn't want a further surgery again for such kind of problem. So our main aim for the third or first surgery is to get a union. So maybe immobilization for initial 4 to 6 weeks, followed by a further X-ray where you could see some amount of early callus formation, and then you can go for a shoulder and elbow mobilization in such kind of case scenarios.
Right, right, sir, right. And in cases of infected non-union, sir, would you like to do a two-stage procedure, or maybe, initially just debride and keep, put a fixator or even an antibiotic nail or a bead, something like that, and then go for the final fixation?
Yeah, again, infective non-unions like in humeral fractures, again the priority goes to control of the infection. So I think even I usually try to go for an external fixator, especially in case of humeral fracture for 4 weeks. And you can put some amount of antibiotic spacer or stimulant beads locally. And usually the like in the lower limbs with the femur or tibia where infection certainly takes longer time to heal. In humerus, I find out that usually 3 to 6 weeks is a rough time. With all these precautions, usually infection settles down because we are
Absolutely.
able to debride the most of these tissues properly in cases of humeral fractures. And after usually antibiotic nail, even I don't advocate for humerus. because of some technical problems to take it out and those things. So fixator followed by a plate fixation or a nail fixation or a augmentation. The second stage would be my choice.
Right. Thank you, sir. Yeah, over to you, Neeraj.
Yeah. So my first question to you is that, do you conserve humerus fracture at all or no? After seeing so many cases, it looks like you're not conserving at all.
That is certainly one of the usually I try to explain to the patient as to what kind of fracture he is having, and certainly if there are certain ideal indication where certainly we can go for, even I would say that few IT guys who have read too much, they have sometimes advised me to go for conservative treatment. I don't want the surgical options. I know that from my training they are very cumbersome for me to treat such kind of fractures with a conservative treatment with continuous follow-up. But there are certainly few indications where certainly you could go with conservative treatment.
And about the one of the cases which you showed where the plate failed in spite of having 6 cortices. So I think the learning point what I took is that you need 7 cortices, what I understand from the humerus, and not 6. Am I right or am I wrong?
Again, for diaphyseal fracture, I think the 6 cortices up, 6 cortices down, or sometimes I feel that 7 cortices. Recent AO has certainly published that you can have a longer spanning plate. Consider the length of the plate is more important, and I think the 6 cortices on both sides are good enough.
And when you put a longer plate on that, I saw you put a recon plate also anteriorly. So what was the reason for putting the recon plate is what I did not understand.
Okay, so this is just a kind of augmentation plate which you can do, especially in cases of non-unions. So this 90-degree to angle plate to the main plate certainly adds into the stability of that construct. So you can start ambulating very well, and the amount of callus formation in few studies. So again, this is just few papers only have been published in this series, but I have shown you one X-ray also in my patient where I put this plate, and you could see the kind of callus formation is much better. So with my limited experience of doing this kind of dual plate configuration like augmentation plate, around 11 or 12 cases I had done, I could get good result. So I feel this augmentation plating needs much research, especially in cases of such humeral fractures, especially near the isthmic regions where most of the instability happens. So I feel the single plate may not suffice. So this plate is certainly very useful, and maybe I had now writing down this number of cases and maybe come up with the paper whether this will certainly should be useful or not.
Okay. And about these, when you do all these revision cases or these non-union cases or infected non-union malunions, how easy it is to explore the radial now? How much time do you actually give to explore the radial now? Because I feel that whenever the humerus comes to me, basically, I feel that the first thing I will explain to him that your radial now can go. If I'm taking a posterior approach. Though it will come back, I know that it will come back because I'm not going to cut the now, but basically because of neuropraxia or a little bit axonotmesis, it will take some time to come back.
Yeah, absolutely. Like most of if the initial surgery has been through the posterior approach, and we are again exploring to the same incision, the nerve will be certainly in some kind of scar tissue. But still the location of nerve is always very constant. Means after doing so many surgeries, I would be able to understand the course. But certainly sometimes in older patients where the muscles are thinned out, the nerve is very difficult to locate. But somehow if you find out more the nerve proximally, and then you can go on exploring over the shaft and distally as well. So at one point of location, it is very easy to identify. If it is in the scar tissue, I try to get few soft tissues along with it, and I know the proximal and distal extension, try to avoid that area and put a plate for fixation below that nerve.
Okay, so do you have a clear-cut guideline for people of our viewers that when should you, in a simple primary humerus fracture, when should you do a interlock nailing and when you should do a plating? Or there is no such guideline, it's just your convenience. How is it?
Yeah. So like the many studies now have come up. Now this is recent meta-analysis in 2016 where they have studied the 3 fixation methods. like the plate fixation and the nail fixation, and even now the bridge anterior plate fixation. So they have found the comparable results in all the case scenarios. So the union rates, the non-union rates, the infection rates are almost equal and comparable. So it all depends on your choice. That's what I'm trying to tell. If I am very comfortable with nailing and I feel that the results are much better, I will not have much of shoulder problems. I will get a good compression at the fracture side. The nailing is also a good option for a platers who are used to plating like me. I am very fond of plating in most of the situation. So I will certainly go for plate. So that's why I have shown you that first example for again transverse diaphyseal mid-shaft humeral fractures. Everybody will they have their own method of treatment, whichever they are comfortable with.
And one last question is that if you're not, I know that you've not nailed much, but whatever limited experience of my nail is that the humerus in Indian bones, especially younger patients, short patients, their canal is very narrow. And
Yes.
the humerus nail, the 7 mm where the guide wire is supposed to go is not there only. Means
Yes,
the
yes.
6 mm nail does not have a guide wire. So it is very difficult
Exactly.
to negotiate that nail and do a close reduction at the same time. It takes a lot of time. So I think it is easier to plate it and fix it.
So that's what I try to come up. Now this controversy will always come, but if I sit across with a nailer who is very routinely and frequently doing a nail, so he will come out with his own solutions, some rimming or even it will not be cannulated nails for a shorter these things.
Yes.
And even I find those difficult. But once you start getting well into that technique, and if you try to convince the nailing person to go for a plating, so I find absolutely no problems with plating. I can do any shaft humeral fracture with any kind of plate putting anywhere on the surfaces. But certainly a nail has got its own indications, like I especially told, like for particular few absolute indication, you should go for that. It is like I am not comfortable with that technique, so I should not do it. But it should also be implemented, and it has got equally good comparison. Only few like these shoulder problems, only they are seen more, sometimes reoperation rates, but again those are getting lesser as you progress with more number of cases. And canal diameter is usually again this problem is certainly, I think a few Indian companies had devised the very smaller nails, but again I am very skeptical that they will break inside. There was a lot of manipulation, and I find the distraction is very common because with a distal very narrow canal, so those problems are bound to occur. But sometimes we'll able to find some solutions for those.
Okay.
Right.
So thank you very much, sir. I think that's all for today. So we thank Dr. Manoj Pahukar to spare his precious time and come with us, as now we have all gone back to almost routine work every day. And we thank Dr. Salim Patel to be with us and moderate this session. And most of all, we thank all of you viewers who have been there with us in this OrthoTV original webinar series every Saturday since the lockdown. Thank you, everyone, and good night.
Thank you. Thank you.
Thank
Thank
you,
you, sir.
Neeraj. Thank
Thanks a
you,
lot.
Salim.
Thank you,
you.
sir.